you very much. So the next meeting we have this morning is the Public Health, Safety, and Justice Committee, which is chaired by Councilmember Hamill. I will turn it over to him at this time.
Okay, thank you, Council President Stone. We have one item before us this morning here, and this is the Community Paramedic Program update. Before we begin, I want to let the committee members and council members know that I spent a fair amount of time last week at Fire Station 1 working with Chief Hewitt and Chief McDermott, and also spent some time at Prospect, which is our call center for emergency calls for medic and fire. I just wanted to acknowledge the people that work in that department. What I saw there was a level of professionalism and care and dignity that was, when people call that number, when they call 911, they're probably having one of the worst days of their life. When they do that, when they're traumatized and their loved one is hurting, Bellingham fire dispatchers bring their best. And I just wanted to acknowledge the work that is done there. It's amazing and tremendous. I'm completely in awe of the work that they do. As to community paramedic, one of the first things that I did as a council member was to ride along with Rob Stevenson, probably would have been back in 2015 or 2016. He was the first community paramedic. And what I saw there was an equal amount of professionalism and care that was given to the patients that he was serving. These folks were sick, they were ill, and he had built a rapport with them that was quite amazing to observe. And I think community paramedic is probably one of the best programs that Bellingham has put forward. Just really impressed with it. Really proud of our fire staff that do the work every day, and as well as the GRACE program case managers that just really display a great deal of care for their patients. And with that, I'm going to turn this over to Captain Joe Frank and Andrea Day for their presentation.
Hi, everyone. Thanks for the kind words. Really appreciate that. Yeah, we do have a great dispatching staff that help us out a lot. And it's nice that they're centralized too, that I can just step in and ask questions quickly and get answers. I'm going to share my screen here and we'll get this presentation started. My coworker, Andrea, she's just clearing a meeting. And so she'll step in a little bit later here. Sorry about that. Okay, are you guys able to see this here?
Yeah, we can see it.
Okay, so community paramedic program. We're gonna talk about a quick review, what's new, some statistics, successes, and challenges that we've all been seeing here. Again, my name is Joe Frank. I've been a community paramedic here now I'm in my third year, working alongside with intensive case manager from GRACE, Andrea Day, and really privileged to do this work and provide the care for these people who really don't respond well to traditional medical help. So a quick review here. Ferndale, since the last time we spoke, I believe it was 2019, we've added 2 county community paramedics. Ferndale Fire District 7 provides a west community paramedic program west of I-5, north to the Canadian border and into Point Roberts. And Bellingham Fire provides the second county medic who covers east of I-5 up to Mount Baker, Sumas, and then also south of Bellingham into Alger, Sudden Valley area. With that being said, the east of I-5 medic that comes out of Bellingham, also about 70% of his caseload is within the city limits, just because of the amount of high utilizers that we're experiencing. So he does leave 30% of his caseload open to those East County fire departments. It's just the need isn't as great as we were expecting out there. And so he has the availability on his caseload to help me out within the city limits. And then just quickly, my rig, CP1, we respond only within the city limits of Bellingham. Some services that we're providing is primarily what we pride ourselves on is resource connection. So we find people in crisis who are using the 911 system for anything and get them directed to resources. And that's what we're really good at. There's a lot of resources within our county. It's just knowing how to get there and who does what when can be the challenge. And we've kind of made that our specialty and can think outside the box to get these people that, like I said before, don't typically respond to traditional medicine, get them into services to help them get stabilized. Another service is education to community partners. So we have a lot of players in the county that we work closely with, Catholic Community Services, Lighthouse Mission Ministries, the list goes on and on and on, Opportunity Council. And we will help them out with Narcan training, all the way down to basic childbirthing classes for Opportunity Council. A quick example, somebody who was pregnant with schizophrenia was paranoid of everybody and everything and 9 months pregnant, and they wanted to prep for anything possible. So we were able to go into that facility, help teach staff on what to do, and try to build a rapport with that person to help deliver if at all possible. So that's a kind of a big service that we provide to our community partners. And then we're also a resource for those community partners. So let's say the homeless outreach team is out in a homeless camp and they find somebody with some pretty bad feet and they're in a lot of pain. They don't really need 911, but they want some, or they don't even want 911. They will get a hold of us and we'll try to make time within our day to go out there and take a look and see how we can help get them some dry socks, get them up and going, and maybe connect them with urgent care if that's what's necessary. Thresholds. So the thresholds to get enrolled into the GRACE program, it's pretty simple in the city limits. If you call 911 12 times in 12 months, you're on our radar, and we will do everything we can to get you enrolled into our program, get you connected to services, but sometimes it's very challenging based on the clientele at need. Once you have gone 3 months without a 911 call, you're considered graduated. We assume that we've got you connected to resources and you're doing well on your own. And then out in the county, it gets a little bit more murky. It's really based on fire department needs. So for instance, Acme Fire, they don't run a lot of calls out there. But so if somebody calls 2 times in 1 week, that might be enough to trigger a community paramedic response. So what that looks like is the fire chief or the person in charge of getting a hold of the community paramedic will contact them, talk about the case, and then they will make contact with the client to see what resources they're lacking. And then for East County, for West County, they see a lot of high utilizers out there. So District 7, Ferndale, they stay pretty busy based on just the clientele that they are seeing. The thresholds is something that we've always, the pass-through is something that we've always done, but we just started tracking in 2019, and it became really useful in 2020 during COVID. Pass-throughs are people who don't meet our criteria for high utilizers, but they're in crisis right now and they're causing issue with one of our community partners. They can give us a call. Let's say somebody's going through a episode down at Lighthouse Mission Ministries base camp, and we'll show up, try to de-escalate, figure out what's changed in their life and get them connected. And it's not necessarily a 911 call. They don't think it's an emergency, but there's something going on right now that needs help, and we will help them out. Also, if it's a pivotal appointment, so let's say Opportunity Council has been working with somebody for a really long time to get them into primary care, but they don't have a ride because they've been trespassed off a WTA. And homeless outreach team calls us and says, hey, they have this appointment. We can't get them there. The Opportunity Council can't transport right now because of COVID restrictions. They'll give us a call and we'll try to make time to transport that person for them so they don't miss that pivotal appointment. And we started tracking that stuff. And in 2020, the city units, we had about 70 pass-throughs, almost about 6 a month for that entire year. And it's been something that we definitely see a need for, and we can't always help them out, but we'll do what we can to help out our partners. What's new? So the big thing that the fire department's proud of is we kind of paved the way, changing the scope of practice for paramedics in Washington State. We added 3 medications to help, 2 help with psychosis, and another to help with reducing cravings to alcohol and opioids. We're able to connect with people where they're at and give them these medications. If you can think about how busy the mental health care system is in Whatcom County, a lot of people, the case managers that are handling our clients, are overwhelmed, and they have one sliver of time to come out and give this person an injection. And if that person isn't there, which happens quite a bit, they have to wait a whole another week to get them scheduled in on the appointment, where we're pretty flexible and are able to jump in that instance and give them that injection, find the person, grab the injection, and give it to them. And it was a huge gap missing. And with the help of the Department of Health of Washington State EMS program manager and our medical program director, Dr. Marv Wayne, we were able to get these protocols going and write a community paramedic protocol to help establish guidelines for the whole state to follow. We've hosted quite a bit of ride-alongs based off of these protocols, and I think Bellingham's really paving the way for community paramedicine and how people receive healthcare. Some new things with Grace: they added a nurse practitioner, which has been huge for us. Unfortunately, she now has moved to the East Coast. She's still available by phone, and we're trying to hire a new practitioner, but her ability to reconcile medications and give us prescriptions for simple things has been a game changer, really, for us. Otherwise, we have to try to figure out ways to get them to their primary care doctor for an abscessed tooth just to get a prescription. And a lot of times they don't want to go, where she can meet them in the field. And together, we work together to help wound care and other big issues that people don't want to go in for, and we can meet them in the field where they're at and really make some changes. Some quick statistics. So from July 2018 to 2020, Grace served 179 individuals. Of those, 74 graduated the program, 50 people were permanently housed, and we connected 100 people to services. Of that 179, 70% of them were diagnosed with some type of a mental health disorder. 52% were battling substance abuse issues, and then 40% were experiencing homelessness. And then to kind of go along with those statistics, just the city 2 rigs, my rig and Aaron's rig, we were able to actually jump 17 fire calls in that period. So let's say we're driving around the city and we hear a fire alarm go off, and we know the area, we know the building, we probably think it's one of our clients that have pulled the fire alarm. We're able to jump that call, cancel all the engines, and handle the situation. And then we also jumped 109 EMS calls. A lot of those are probably our clients that were calling 911, and we heard the address, we jumped the call, cancel all the rigs, and are able to handle the emergency by ourselves. And then a few of those calls are us driving by the scene, essentially, of a 911 emergency, and we're able to handle that situation without tying up a bunch of resources for a simple issue. So some successes. I actually got this graph from Laura Christensen, the Grace program manager. It's a lot more difficult now to get numbers because of just how big Grace is getting and how many different units are in operation. But as you can see here, the big takeaway from this is that pre-enrollment, the rate of utilization is much greater than graduation. So just focus on the big, tall, light blue bar. Our caseload produced 1,419 calls. The caseload of Grace made that many EMS calls before we enrolled them. And then after enrollment and graduation, that number dropped significantly down to 205 calls. So it's a 85.5% reduction in EMS use. And to put it in dollar signs, pre-enrollment, it costs taxpayers $3,265,000. Post graduation, those individuals cost right around $471,000 with their current calls. Those numbers are so great just based on what it costs and we get these numbers based off of the ground emergency medical transport. So to run the Bellingham Fire Department, if you call 911 and you get a fire engine on scene, that costs right around $2,340. So that's a big number to just get a fire engine to come out and take a look, or a paramedic unit to take a look and see what's going on. And that's where we can really make an impact and make a difference. And our challenges. Our big challenge is just, these are in no particular order, but this is something that Andrea and I sat down and kind of came up with. Limited placement options. There's nowhere to take people. A lot of what we're doing is just shuttling people around, and just trying to de-escalate the situation at the time it's happening, and then hope for the best afterwards. We just can't. There's no options for people. Transportation, especially during COVID, that's a huge barrier for a lot of our clientele. Just to wait somewhere to get a ride to a doctor's appointment is nearly impossible. Where we're able to overcome that with our vehicle, but even that's limited just based on the size of it and the amount of things and stuff that people want to carry and take with them. Weekend coverage, we hear this all the time. Even like our clients know our schedule. So a lot of them that are being defiant will call us after hours or call on the weekends, 911. And they'll specifically tell dispatchers and crews, don't tell Joe I called. And still they know they're doing it, and they know our schedule. And we frequently hear it from our community partners and engine crews, just hoping that we can stay on, past hours and weekends, which is just obviously something we're not doing quite yet. Mental health care. We have two big community mental health care agencies in the county, and one of them is so busy right now they can't take new clients. So we're just really lacking in that area, and we're feeling it. And then another big one is discharge planning and coordination. It seems like all of our clients, when they get back from treatment center somewhere or they get out of jail, they're always released on a Friday after work and on a weekend, and then they're right back to their habits that make them comfortable. And then we try to find them the next week, and we spend a week trying to locate them, and they've already spun out. Universal ROIs. Grace has a great ROI that lists all the care agencies we get our clients to sign so we can talk to them, but a lot of the care agencies won't accept that, so we have to get their ROI signed, and it makes it very difficult to get the person we're dealing with to sign 2 ROIs based off of another agency's need. And then the Involuntary Treatment Act limitations. So it's super difficult to get somebody detained for mental health reasons. Even, working with, side by side with the Bellingham Police Department and designated crisis responders, we frequently see people who are spun out, and just based off of laws and other things, we can't detain them, even though we feel that they're not baseline. The way the laws are written prevents us from actually taking that person's rights away and doing an involve on them. So there's a lot of people that we're with downtown that are struggling, but based off of the laws written, we can't, help them officially. So that's what I have. And I'm ready for questions if there's any questions.
Thank you, Captain Frank. Can you go ahead and stop sharing the screen? We can get our committee members present on the screen. Okay, there we go. Thank you. Thanks for the presentation. Committee members, questions? Councilmember Huffman.
Thank you so much for that presentation. It's so exciting to see the outcomes that you've presented, even if they're just really some of the basic ones. And despite all of that huge list of challenges, that's pretty incredible. So I feel like we need to start chipping away those challenges. What the first one that you listed was limited placement options. Can you give us a little bit more detail on what kind of placement options you'd like to see, or what would be most helpful?
Looks like we lost the video for Captain Frank. Chief Hewitt, do you want to, maybe while Captain Frank is getting adjusted there, do you want to maybe chime in on that one?
Yeah, I'm hopeful Joe will come back up online here because he knows the system very well. But I know from my conversations with him, we definitely, when we're talking about crisis triage, the new triage center that's open already can use more beds, more staff. Same thing with our addiction services, and hopefully Joe maybe heard what I said and can jump back in now. No, still see IT in the background helping him there, but no, I think that's the biggest thing is that when we have folks in crisis, we have the new triage center in town, but as it's opening, it's already overwhelmed with between beds and staffing, and there we go.
I'm back. Sorry. I'm really sorry.
Were you able to hear that, Joe?
No, I couldn't hear anything. I'm sorry.
So we were just talking about the on your slide, on your challenges, when we were talking about facilities to be able, I can't remember actually the exact term you had on your slide, but as one of the challenges there, having places to be able to take people. You want to touch on that a little better?
Yeah. So there's no, we work with the most difficult population that the city sees. And a lot of these people are in and out of services frequently, and they leave a bad impression. And it makes it difficult for them for facilities to want to take them back just based on previous behaviors and things of that nature. We really don't have a facility locally other than the emergency room that will take people who are to our level or to the level that we see. And it's unfortunate, but we just aren't there yet. And I don't know what the fix is for that other than, building and staffing a facility that can handle a challenge to that degree.
Before I acknowledge Councilmember Knudsen, I want to follow up on this. This is really frustrating to hear. The Crisis Stabilization Center that Chief Hewitt is referring to was long in development. I serve as the chair of the Behavioral Health Committee on the Incarceration Prevention and Reduction Task Force, and we knew that having a facility would not answer all the questions or address all types of issues, but we thought that was going to give us a better shot at it. That the facility, just so it's on the record, so the public understands this, is a 16 and 16 bed facility, 16 for substance use disorder and 16 for mental health illness crisis, psychosis. And the reason it's set at 16 is because of Medicaid reimbursement rules. We are a little bit hamstrung on that, but we felt that it would give us a little bit of a head start. I also want the public to know that this is a regional facility. This is not a Whatcom County specific facility. But it's troubling to hear that that's not helping to the degree that we thought it would be. And Captain Frank, I don't know if you can expand on that a little bit and maybe give us some insight.
Yeah, so we've had the Crisis Stabilization Center since I've been here, and then we've built a new building to put them in. There's just a lot of growing pains and challenges, and it's just things that, I just can't emphasize enough how difficult a lot of the people that we work with are, and the reputations that they have created in these facilities. And that's a lot of times what we see is they've been in this facility, they've been accepted into this facility at one point, but it's a community space. It's not just them in treatment. It's, like you said, 16 to 32 additional people in that building. that will, if they cause a disturbance, it can cause a lot of difficulty in treatment for them. It's a great spot for a certain clientele, but not all. And we deal with that clientele that is, at a greater need of care that can cause the most issues in a facility. So.
Okay. Okay. Thanks for expanding on that. Councilmember Knudsen.
Yes, Captain Frank, thank you very much for your presentation. I want to echo the words of Chairman Hamill when he first began. There's no secret that we have one of the finest paramedic programs in the country as far as I'm concerned, because I've done a little research on it and going to another community for vacations quite a bit. What our people have to do 24 hours a day, 7 days a week. I just want them to know it doesn't go unnoticed. I know the council fully is understanding, and I hope the public is, because people in Whatcom County, they know three numbers, and that's when they call 911. They want somebody to come, and that's why we did the levy. That's why we're going to hopefully do another one and keep this program going, because it's very essential for the work that needs to be done now. And thank you very much.
Okay, committee members, other council members, Councilmember Lillquist, and then I'll recognize Council President Stone.
Thank you for recognizing me. I had Holly's exact same question. If our problem is nowhere to take people, it'd be nice if we could solve that. Captain Frank, it sounds like it's not that easy, but any ideas you can come up with? And I have a similar question. You also said that there's no room for new clients at one of the two major local mental health providers. What can we as city officials do about increasing the capacity in the mental health system? We don't have mental health providers as city employees, but what can we do as a city entity to increase the capacity in the county system?
I mean, obviously, it's not just here, it's statewide. We frequently throughout the state are trying to get people placed places, and there's just not beds available. All the way, I mean, we'll see Port Angeles ambulance at St. Joe's parking lot because St. Joe's is the only mental health bed available on the I-5 corridor. So it's not just a Whatcom County thing. I think we have a lot of resources available, but for the local community mental health care providers, I mean, it boils down to staffing issues and just availability. There's a lot of turnover in both of these agencies, and it's difficult to keep them, keep the continuity with patient care going. And I think it all, like everything else, boils down to, what you're willing to fund and how. And I'm not sure if it's something that we can do as a city to pressure them. But I don't have the answers to that. I just know that it's not just focused in the county. It's statewide right now.
Well, thank you. It sounds like this question might be above your pay grade, but are we a funder, or who is the funder, who needs to step up? Who do we need to talk to, or do we need to talk to ourselves?
The two agencies in the county are regional agencies that are privately funded to private practices. Am I correct? They have a lot of, I think they get federal funding too, but primarily it's nothing county funded.
Yeah, I'll
Go ahead, Chief.
let Joe off the hook a little bit on this one, because it is very much a bigger question, Councilmember Lillquist, on how we, as we look at the available pool of workers in the mental health field, we've got to find a way to make that more attractable, and or attractive to people to get into that field. And when I say we, I mean we as a society. This isn't something that the city can necessarily fix, but we definitely are seeing just within the community paramedic program. As Joe was saying, we have our nurse practitioner that is being vacated, and they have a harder time drawing somebody into that position. We've got an open, one of our teams is running without their social worker here for about 6 months now, because they're having troubles attracting people into that field. this is the growth industry, unfortunately, in our society right now. Yeah, and I mean, it's great that we're finally addressing some problems. It's unfortunate that it's a growth industry, but we've got to figure out as a society how to better fund that, better attract people into that work, because that's where the majority of our workload is going right now.
I'm going to add in on before I recognize Council President Stone and Mayor Pro Tem Vargas. It's a huge issue. Chief Hewitt is absolutely spot on when it comes to the workforce component. This is something that is well beyond a city's obligation. This is probably a federal piece. Those workers in this particular type of healthcare, behavioral healthcare, do not get compensated well enough. There are not enough folks that can do the work. There are not enough private entities that want to take on this work, and it's complicated by the MCOs, which are the managed care organizations, and the accountable communities of health that are a little bit slow on the draw here in terms of trying to figure out the value and importance of addressing behavioral health. What we have right now is good, but it's not good enough. And we need to keep advocating for larger changes at a structural level that's at the state. As you know, as you are well aware, the Blake decision has created an issue with basically legalizing all drugs. Also, House Bill 5476 was referenced by the sheriff not too long ago. That is changing the police response to mental health. These are you can weigh them good or bad, or whatever opinion you have on them, but they are complicating factors. And with that, I'll just take a moment here to stop and recognize Council President Stone.
Thank you, Councilmember Hamel. A huge thank you to Captain Frank and your team. Again, just echoing what people have said, just the complexity of the work that you do, and I'm grateful for your service and that of your team. And I have a bunch of questions, but I'll limit it to one at this time. So we were talking about the piece that Councilmember Huthman brought up about those gaps in placement and where people would go. But you also referenced, because sometimes we hear, I guess, about whether there's lack of services or people not wanting to go, right? And that obviously there's free will at some point, and whether someone's actually at a point where they're willing to accept those services or treatment. And so you mentioned that there was some restrictions on the laws where sometimes your hands were tied with respect to sort of involuntary treatment or provision of services. Can you speak a little bit to what level that's at? Is that local, state, or federal restrictions?
It's state and federal restrictions, just based off of to take somebody's rights away is a big deal. And if their baseline and their mental health condition, or if it's a drug-induced mental health condition, and they can freely speak and talk, even though it might not be something that we would think is okay, you can't, take their rights away and involuntarily commit them for those reasons. And a lot of the calls we get in 911 are for people who are causing a big disturbance and a big scene. And when we show up and talk to them, even though they are acting on their paranoias and their hallucinations, when we speak with them, they are of sound mind, and or they are using drugs that are causing the psychosis, and you can't take their rights away for those reasons.
Councilmember Vargas.
Thank you for this presentation, and huge thank you. I feel like the community paramedic program is probably one of the best things that we did for this community, and thank you for that. I have two quick questions. One is, in my world, ROI means return on investment. So I don't know what an ROI means in this case, if you could explain that. And then secondly, you talked about the jail release. And I'm wondering if that is something that the GRACE program has addressed in how we are reinstating people back in to the community. And if that jail release happening Fridays after everything's closed could actually be changed, because I'm sure that there are a lot of things that might be affecting in regards to people's re-release back into the community?
ROI, I'm sorry, it's release of information. So it's a form that we have to sign to be HIPAA compliant. So we can talk about a patient with their other care providers. And so they'll sign our form, we'll get that filed, and then sometimes other agencies want us to fill out their own release of information to talk about that client. It's just to keep, give the patient dignity and keep their privacy. And then it's not just a local jail, it's all jails in the state. I mean, we could try to address the Whatcom County Jail, but honestly, they're so full right now that they're not taking a lot of people anyways. It's people coming back from Yakima or coming back from a different jail or prison in the state. They'll get dropped off. They won't have medications, and it'll be on a weekday or a late afternoon. And that's just based off of travel. So they could get released at noon, but the bus doesn't show up to Bellingham until 6 o'clock. It's just unfortunate. And I wish it was a simple, let's just go. And I'm certain that the Whatcom County Jail would work with us on that, but it's not. It's a statewide issue.
Before I recognize Councilmember Anderson, I just want to make sure to clarify some earlier remarks that I made. This is the issues are not, are not a reflection on Bellingham Fire or the city of Bellingham staff members who are working diligently to come up with solutions and help people. That is not at all a reflection on them. They're doing that in spite of these external issues at the state level and the national issue of not addressing mental health. So I want to make that abundantly clear. I'm fully supportive of the community paramedic program, and they do outstanding work. Councilmember Anderson, please.
Thank you. But something that you said kind of has been something that's been in the back of my mind for a while. But when you mentioned that going, at St. Joe's and seeing an ambulance or transport unit from another county because St. Joe's might have the only mental health bed available, I'm just wondering, do you know what happens when individuals are released from St. Joe's? I see two scenarios. One could be that an individual does have connections in the community, whether it's a job, family, home, and another location. It would seem that, are they transported back to that community, or they have to make their own arrangements? But also if someone is houseless in another community and then is brought locally for services, is there some kind of coordinated arrangement in order to be able to make sure that they're just, and I don't mean make sure, but that if they're just released, do they just say goodbye at the door at St. Joe's and then they're kind of raftless in Bellingham and having to figure out how to connect to services and I'm just thinking, regardless of being housed or houseless, when you are part in a community, you have your favorite coffee shop, the people at the library. And I'm just wondering if these individuals are being made connections in order to be able to receive support services from the community that basically brought them to St. Joe's, if you have any idea how they are exited and coordinated with services when they're not from the Whatcom County area.
So obviously the hope is to get people stabilized when they are involuntarily committed or they want a voluntary bed. The social work at the hospitals will do the best they can to find whatever bed's available. If that's their local hospital, they'll get that. If not, they'll find a bed for them. But the hope is after that stay, they are stabilized and can make their own decisions. And if they are stabilized and deemed of sound mind, and they walk out and they were houseless, down in, Vancouver, and now they want to be houseless in Bellingham, that's their choice. They can do that, and we have no say about it. And there's nowhere to, if they're not causing any issue, there's no resources that they need other than, however if they deem they want to camp or buy a motel, there's just really nothing. A lot of times once they are released, they're supposed to follow up with their primary care physician. And if they don't, then they start spiraling again, and it's a revolving door, which is unfortunate. We are seeing people showing up from other counties because other counties are busy. They don't have resources available anymore. They don't have any more shelter space. They're not feeding people outside of the shelter. They're only feeding people inside the shelter. So people just migrate to where the services are, and we're seeing that. We're seeing a lot of that. So we're working with other agencies to get a hold of that and either contact family members in other counties to see if they can help with the person that has arrived from California. But a lot of times there's just nothing that people can do, and we just have to work with what we have in the county.
If you don't mind a follow-up, I guess, I would maybe assume that is a substantial need that we might have. That's maybe it is being filled, but for me, it's not so much that, someone chooses to live in Bellingham. My concern is that even though they have free will, hopefully they're stabilized, is to be able to ensure some type of connection to services to try to help prevent that spiraling out and then becoming a revolving door, because being in a new community could be unstabilizing as it is. So I was just kind of wondering if there is like an exit handoff to support services should they decide to be to stay in Bellingham. And you may not know that, but it just I'm just kind of wondering if there's that gap there with coordination.
And there is. That's all part of discharge planning. They'll even try to set up an appointment with their primary care or mental health care provider before exiting the facility. It's whether they want to participate in that. And if they're new to town, to get a new patient appointment for mental health care is nearly impossible, or it's months out, and then it's more difficult. If they want to go back home, there are Medicaid, Medicare transport vans that can take people back home, even if it's counties away.
Council President Stone.
Yeah, thank you. Just one quick follow-up question as well. So you'd mentioned the ability to jump calls, which I think is great on a number of levels. Just when you can identify a location or an individual that you already have that relationship or history with, and are able to sort of intervene. And one of the things I think about is our, research about 24/7 unarmed crisis response and what that might look like. And so I'm just curious from your perspective, have there been times, or how often, when you jump a call, has there been a need to call in resources that were called off previously, if that makes sense at all?
Sometimes yes, just depending on what we find when we get there. Sometimes, rarely will I ever have to call back fire. If it's a fire response or EMS response, typically Andrea and I can handle the entire emergency or urgency that's going on. But sometimes I'll have to get MCOT involved, or I make a lot of phone calls to our behavioral health officers, deputy clerks, or Zach Sarad. So sometimes I have to get them to come over and help with a situation. But it's rare that we have to upgrade for EMS again. Our vehicles are equipped like an ambulance, even though they don't look like it. We have everything to run every emergency in there. So it's rare that we have to get crews to come back. We might have to add other crews that people haven't thought about.
And you mentioned, was that MCOT? What is that?
So Mobile Crisis Outreach Team through Compass Health, and they do a great job. We use them quite a bit. They just can't. They're 15 to 2 hours away. So our engine companies can't wait on scene for a 15 to 2 hour response. So it's difficult. Where Andrea and I are more familiar with how it operates, and we can find other ways to get people to wait around for MCOT to show up to help them with their mental health care crisis. And then sometimes we can just get a DCR to show up. Like I can talk to the dispatcher at MCOT And she's like, okay, yeah, I'll just send you a DCR and then we'll wait around so they can do an evaluation for involved.
Okay, so one last acronym. You said DCR. Was that the last?
Sorry, the designated crisis responder. So those are the mental health care professionals that come out to the field that can determine if somebody's of sound mind and need to be involuntarily detained. And the way what that looks like briefly, if I show up and I see somebody in crisis and I'm like, oh my gosh, they need to be detained, I'll call MCOT, talk to one of their specialists, and they'll either say, we'll come out and take a look, or we'll just send you a DCR, the designated crisis responder. If the DCR comes out, they're the ones that have the power to detain and write a custody auth for pickup. And a lot of the strategy that they do is if I can't de-escalate them and they can't de-escalate them, that we'll call for an involve. So we'll get BPD involved, typically a behavioral health officer. And a lot of times the DCR will see if BPD can talk to the person, because they're really good at de-escalating most of the situations. And a lot of times BPD will be able to convince them to go in involuntary with me, and we'll take them into an involved bed. But then if that doesn't work, then the DCR will actually write the custody auth to get them involuntarily detained.
I want to expand a little bit on that just for the benefit of Council President Stone and others here on the call today. We already have an unarmed response unit, that is MCOT, which is what Captain Frank is referring to. They respond to about 150 calls per month. They are referred to through law enforcement, so it's not a 911 necessarily kind of unarmed response. But we are working on that piece of it. I have grave concerns over 5476 passing. That means on July 25th that sheriff's deputies and BPD will not be responding to mental health calls. That means that we need to fast track the unarmed response that we have that we've been working on for a while now. And then the other complicating factor is that we will have a 988 system theoretically coming online next year, theoretically. That means that instead of calling 911 and not really knowing who's going to show up, if it's going to be police or fire or DCR, at some point, 988 would just go strictly for behavioral health professionals who can address the situation unless it's dangerous. And then in that case, a police officer would be dispatched. It is not clear to me that the legislature or the state Supreme Court has thought through the implications of the Blake decision for the state Supreme Court that makes it so law enforcement will not. They cannot arrest someone for using meth or cocaine or other dangerous drugs. And 5476 is just a complicating factor that's coming out of the legislature. It is unclear to me a pathway forward. And it seems like sometimes when we do all the work here at the local level, other external factors complicate things. But I'm glad that we have community paramedic program in our community. There's 291 cities, over 10,000 people in the state of Washington. We're one of the very few that has been forward thinking and really works towards the PITA continuum of care, the prevention, intervention, treatment, and aftercare. We are one of the few counties that has a 0.1% mental health sales tax that we are able to actually fund the PITA continuum of care. And we're also prioritizing this at the city level. I think it's sort of universal with council and with the administration that we value and we recognize prevention and intervention so that people can get the help that they need. And I think that's just it's just really I'm proud to be on the big team that's doing that. Chief Hewitt, go ahead.
Yeah, I appreciate what you're saying there, Councilmember Hamel. And as we're hoping to come back again here next meeting and start breaking down more of the strategic plan for the fire department, one of the big things you're going to hear me say over and over again is we need the right tools in our toolbox. We have, historically 911, you've had three choices, police, fire truck, or an emergency medical provider. And I emphasize the emergency medical provider, folks that are that are looking for or that are geared around heart attack, trauma, acute emergency type medical issues. We as we've evolved as a society, we need to change that. We need some additional tools in our toolbox. We need more of, whether it's MCOT or more community paramedicine, more behavioral health officer coordination teams. We need more tools in our toolbox. And you're absolutely right. It is becoming a much more rapid discussion with the legislative changes. We're already seeing an increase in the number of calls that EMS is being dispatched to that were historically law enforcement type responses. And unfortunately, with the tools in our toolbox, we're sending an incredibly expensive and inefficient tool to those calls. And by the way of our cross-staffed fire companies. So we're sending 3 people out in with a fire truck and an ambulance to handle some of these calls that would be much better served by the correct tool, such as our teams of paramedics and social workers. So a lot more of that to come, but I appreciate the recognition there. And I also just take an opportunity to echo, Joe and Andrea and Aaron and Christina, the teams that work here out of BFD, excellent people doing excellent work every day. And I can't say enough about them. So.
Thanks, Chief. Can I add on to that, Councilmember Hamel?
Sure, go ahead.
Just to give you an idea, when he's saying expensive emergency apparatus, a few of our top callers, the people that we see frequently before we get them enrolled, and then after, one person had a Bellingham Fire Department emergency apparatus at their address for 27 hours and 50 minutes, just in a 7-month period. So that's out of service time for one fire engine at one address with other calls coming into their area. So it's pretty significant. And there's several that I can go down the list and just add times.
Yeah, when I first started, I had talked with Chief Newbold, and he said that the high utilizers of the system were and it's a small number of people, but they call frequent, or they did call frequently, is the equivalent of shutting down a fire station for half of a year. That's the out of service component. So I'm just very thankful that we have both community paramedic and Grace. They're helping people get the care that they need. And I'd like to point out that out of the prosecutor's office, the LEAD program also provides some additional behavioral health case management. Between Grace and LEAD, that's about 180 plus slots for folks for case management, where they can get more specialized level of care, and they're not utilizing this for chronic illness. They're able to access care, and they have complex case situations. Captain Frank is absolutely correct on that. It's hard to treat some folks because of just their situation and their condition. But I do want to. I'm just going to look across here for committee members or other council members. Any other questions here? Okay. I do want to take this opportunity to thank Andrea Day and Captain Frank for coming and sharing their work with us today, and a special thanks to Chief Hewitt and Chief McDermott. I was able to spend a lot of time last week, and really, there's no replication for that. I think every person, every citizen of Bellingham should spend an hour in dispatch and talk with our community paramedic staff members to get a better understanding of what this of how they prioritize patient care. Really thankful for their work. And if there are no further questions or comments, this will conclude the Public Health, Safety, and Justice Committee.